So the last presentation is by Dr. Coselli, who's going to present really his work in developing grafts in the thoracic aorta with Vascutek to remove aortic.
Last talk, hard to keep things interesting, but we'll go through a few things. Potential disclosures here. This is a classic elephant trunk operation where you leave a soft Dacron tube back in the descending thoracic aorta following arch replacement for later use, which can be used for a open repair, or as we know that in these, completing the second stage was 53% to 61% in many of these cases, and the vast majority were open repairs, but also can be used as a landing zone for endovascular repair. And having a frozen elephant trunk with a stent graft in that little Dacron portion of the descending makes this even easier. In the early days when we did this, we would actually accordion the graft sometimes with the wire and the device. And one of the things I used to do is put a coda balloon at the very end and let the pulsation and pressure bring it down to a fuller expansion of the graft. So we're supposed to talk about the Thoraflex. The two that are really popular for this are the Vita Open Neo, which is available in Europe, and the Thoraflex is available in the U.S. Almost 2 years now, and is worldwide. It looks like this. It's a hybrid device. It's been talked about earlier. This is just a drawing of a case of acute dissection where it was used with an extension in down to just above the celiac axis. So we look at the frozen elephant trunk position paper from Europe. It really is useful when you have a second procedure where the downstream segments can be anticipated for the need of an open or endovascular repair. And these recent guidelines point out that a qualifying factor for considering open versus frozen elephant trunk is whether the primary distal seal will be achieved with the frozen elephant trunk, and in the absence of that, can it be extended? And with regards to complete endovascular approaches, they mentioned that you need to have institution and individual surgical experience, because most of this is really with investigational devices. However, the frozen elephant trunk is a simplified hybrid approach. It does require circulatory arrest, and it combines both open and endovascular techniques and can be used in pretty much all transverse aortic arch pathologies. The Thoraflex device, as you see here, and is going into distal to the left subclavian artery in these drawings, but it's a device that's placed in the descending thoracic aorta, and it's deployed. There's a cuff to suture to the aorta in a circumferential fashion, and then it has branches or no branches, and then can be used to replace the rest of the arch down into the proximal ascending aorta. This is a case that we did, and replaced the ascending, placed the Thoraflex device, and I extended down to the celiac axis, just in the, as you saw in those previous drawings. And here's the final angiogram. Now, this is the trial that for approval. The primary group was 65 patients. We had a rupture group of 9, and they were mostly aneurysms and chronic dissections, very few acute dissections. And this is the primary endpoint. So that had at least one MAE was 15% of the cases in the early on, and then 19% out at 1 year. All-cause mortality was low. Permanent stroke was 6%. Permanent paraplegia rate was 3 or 5%. And unanticipated aortic reoperations were actually quite few. And then 41% underwent extension of planned repair at the 1 year level. And freedom from MAE at 1 year for the primary group was 81%. And this is a report, the meta-analysis that Dr. Provenza put together, that I think reinforces that idea of extending distally in these cases. We do have the risk of paraplegia, where if you had the extension down below T8, the incidence of spinal cord injury was statistically significantly increased. Now, when we did the initial trial, the extensions were a variety of grafts: Gore's, Cook's devices, Medtronic, et cetera. And the company has set about what they call the Extend trial now, which is really a registry looking forward with patients who are undergoing Thoraflex devices, implantations, and then having extension with their Relay Pro stent grafts, and so this can hopefully will answer some of the questions. Distally, it's going to be about 55 centers with 200 patients, and the idea is to follow these patients out to 10 years. So this is a meta-analysis of 931 of these thoraflexes and how they did. Mean age was 63, which is actually relatively young, but the early mortality rate was quite low, and neurologic injury was just under 2%, and dialysis rate 0.7%. This is another meta-analysis study looking at a little longer survival out to 7 years was 99%. Event-free survival was almost 95% in this report by TAN. This is a single-center study from Bologna where they used a lot of the thoraflexes early on and compared that with the Vitas, about half and half. The 30-day mortality rate was 13%. They got 3% paraplesias and strokes in almost 8% of patients. The survival rate out to 5 years was virtually the same for the Avita versus the Thoraflex, and it was a little under 75%. And there was no difference between the two. As we've talked about, there's a lot of patients who just simply can't undertake an open operation. They're just too high risk for it, and others just simply dread it and refuse it. So we need some other options. So I was asked to talk a little bit about the relay business. And so the Terumo has this relay double branch graft, and now the triple branch is under investigation. And we've already talked about the fact that chimneys, periscopes, and snorkels have their problems, particularly with type 1A endoleaks. The branch devices that they don't require the precise alignment that some others. You can theoretically be able to standardize some of these, hopefully to be off the shelf, and they can be used both in elective and in urgent cases, not waiting 6 weeks to 2 months to get a device. And these remain under investigational use right now. And so they've got two of them. One of them is the Relay two-branch device. This is the first case that was put in Canada, and it has kind of a self-righting ring, which makes placement of the positioning of the branches a lot easier. And this patient did well to 3 months. Some of the cons of this sort of thing is, however, arch manipulations are required, retrograde carotid access, and there's if you look there at my little red lines on there, you can see access from the proximal vessels down into the descending thoracic aorta can be quite limited, and you have to cross the valve for deployment. So this was the early study. It's about it was 30 patients, most of which were aneurysms. A lot of them were in zone 2. However, they had all-cause mortality was 2 patients, 6.7%, but there were 14 neurological events. One of them was fatal. Of these 14 subjects, 11 were embolic, 3 were hemorrhagic, and 1 was retinal occlusion. And 5 of the subjects had the problem, neurological events were greater than 30 days. 2 of those were embolic as well. And Alan Lumsden alluded to this earlier, and I think this is extremely important when we think about running wires and catheters and what we call clinical strokes. There's a lot of trash that gets thrown distally that probably don't affect these patients till later. And this is a report by Lansky, who really just pointed out the fact that when it comes to strokes, it just depends on how detailed you want to look. And from disabling clinical strokes that were obvious all the way to weighted MRI scans that can pick up much smaller strokes. So this is the, in the answer time, I'm going to pass on. Just look at this. This is the triple branch that is very interesting. As you can see with my red arrow in the upper right-hand corner there, that this will allow access from the left brachial artery or radial artery into the descending thoracic aorta later, if necessary, without having to make the multiple turns. There's not a lot of data on this. This is just a quick paper of 3 patients that was carried out in Florida. All of them were in this triple branch were successful. There were no strokes, no in-hospital or 1-year mortality. All 3 patients, however, did require secondary re-interventions for extension. 1 died 14 months later of the index procedure due to endocarditis unrelated to the arch repair. So the Thoraflex platform facilitates extended repair in complex disease, branched endovascular repair is safe and feasible to treat patients with thoracic disease who cannot undergo the classic operation, but further work needs to be done to sort these out, which patients and which technologies are going to be best, we're yet to see. Thank you very much for your attention.